First of all, I just want to say I'm so grateful to be here with you, Dr. Joe. And before I hand it to you and you have to answer the hard questions that I have for you today, I just want to say somebody who doesn't know, or maybe a bit of a background. Dr. Joe, I met Dr. Joe maybe around 20 years ago. I met him when I was one.
That's about right. Yeah,
That's
you're in diapers.
Yeah, I'm trying.
Decent-sized diapers, but diapers.
I'm trying not to reveal my age. Yeah. He was one of those doctors. When I met him, there was this constant connection about a doctor who wanted to talk about health and wellness. It wasn't about, I want to give you this, I want to take this medicine. So he has been one of those doctors for the last maybe 15 plus years that I've known you. You've been the doctor who's been pushing about wellness, more about in every sense. So I'm very privileged to be here with you as a friend, as a doctor, as a client, and I'm really happy to be here, Dr. Joe.
Tom, it's a great pleasure to be on your podcast and chatting with you today.
Yeah. I want to take this a little bit different because we have so many discussions when we were working together or we were catching up, but I want to take this in a different way. But before we switch into that gear, I just want to understand from a different perspective, what made you think of being a doctor?
And I probably should point out for the listeners, when Tom talks about us working together, I'm the one doing the work. It's like, another 5 reps, another 7 reps.
We are together.
Right. No, we're a team. No, it's good. You're keeping me in shape, and that's really important. Look, like I suppose
it's like a
lot
pilot
of
saying, we are traveling together.
That's the one. Look, like, I suppose, and even back in the day, you go through high school, what am I going to do? And I didn't really have any absolute clear idea. Like some people have their heart set on being, a fireman from the age of 5 or, potentially a doctor from the age of 7 or whatever. I probably wasn't clearly one way or the other, and I was a little bit tossing up. Did I want to be a doctor? Might I be interested in doing law? A lot of my mates was doing engineering. That probably wasn't quite my scene, although interesting, I know a lot of people who studied engineering who've gone down very different paths. My late mother was quite keen for me to study medicine. Her mother, before her, my grandmother, this is in Europe many years ago, had started studying medicine and then switched over to studying law. And I think in those days, this would have been in probably the 1920s, that wouldn't have been that common. So between probably my parents, my mother a bit more than my father, although both were, you need to do what you need to do. Why don't you start, if you got the opportunity to get into it, because back then, same as now, it's not always that easy to get in. You get the opportunity, start. If you really don't want to do it, you can always change tack. And like a lot in life, you start doing something, you get more interested the further you go, and you keep going.
Yeah. Now, Joe, just maybe take us a little bit as a student, and maybe there's a student listening out there who's doing medical or wants to become a doctor. What are the challenges did you face? Not now, but I know there's a bit of a difference in the gap there. The systems have changed, the technology has changed. But what are the challenges you faced to be able to become a doctor?
Look, the first hurdle is getting in, and there is and remains a lot of competition. In those days, it was, I was fairly blessed. It was just entirely based on your, what was then called, what was it called in those days? TAE score. Now it's called WACE. It's called differently in different states. And it was purely on that basis. It's then changed to a combination of, what you've done at school, an interview, an aptitude test, what they call the GAMSAT. So that's number one. It is a long haul. Medical school courses are a minimum of 5 years, and some, if they're an undergrad and postgrad, is 7 years. And compared to a lot of university courses where today you can do a lot of it online, you can't learn to take somebody's blood pressure online. You actually have to be there. So there's a lot more contact hours in medical study than in a lot of other courses, which means that, you're arguably giving up potential to earn some money for a number of years. So you're going to need You're probably going to need the support of your parents and or family, or again, if you're able to get some government support, that can be useful as well. But a lot of your mates will be starting to earn money before you do. You also you do have to want to help people.
Yep.
It is a fundamental. Now, some people are people-orientated people. Others are more backroom type people. Now, look, one thing about medicine also more than ever before is when you talk about being a doctor, well, as a GP, what I do is very different to if I was a psychiatrist, to if I was a pathologist in the lab, or a radiologist, or a cardiac surgeon. Which also means, and look, it's good and it's bad, the degree of subspecialisation these days has its uses, but it can also become quite narrow. So, when one says doctor today, it's not like 100 years ago you somewhat did a whole range of things. Yes, technology has increased, range of what can be done has increased, diagnostics have changed. And one thing for all the students, it is important to remember that you're always going to be dealing with a person. Now, so you're not dealing necessarily just with a heart or with a bone or with a liver. That's a perspective that's really important to keep.
Now, Joe, if you look at the system, how it was when you started getting into medical and being a doctor, and you look at the system that is there now, I know you've been really involved the whole time in the system and being able to present talks and everything. What is the change, and are we heading towards a better system, or is the system compromised?
Yeah, that's a very, very good question. And worldwide, no, I'm actually going to answer it. For those who are listeners, we do have a few in-house standing jokes.
No, for those people who are watching this, this is something that is an in-house joke, so sorry, I do apologize.
All right. I'm fortunate to be travelled to different places around the world, and I'm yet to find anywhere where I would, if I'm sick and unwell, that I would rather be rather than in Australia. But Australia is not immune to the factors facing global issues, which are an ageing population, a shrinking medical workforce in relation to that ageing population. So ultimately, getting medical treatment is becoming more difficult. I mean, in Australia, for example, the population has gone up 10% in the last couple of years, and the doctor population has gone up by about 2%.
Yeah, just to cut that short, I'm looking at the system, not yet about the medical. I'm looking at how to become a doctor when you started and how to become a doctor now. Like the entry process, is it better now than when you were there, or that's? I'm not. We'll come back to the system.
Right.
Later.
Oh, sorry, mate. Look, it's different. When I was getting in, as I mentioned, it was purely based on your high school scores, and there were very, very few mature age students. It then changed, particularly I think in the late 90s. There was this view that yes, you're getting really intelligent people going into medicine, but there was a view that some of these people could be quite one-dimensional. These are the sort of people who'd be up studying till midnight. They didn't necessarily have much, and this is obviously not everybody, but were a little bit one-dimensional. They didn't necessarily have a social life. They didn't have a broader experience. And the idea was then, okay, well, yes, we want people who've got a reasonable degree of intelligence to do medicine, although I should say that conceptually, so compared to engineering, medicine is not conceptually difficult. You do need to remember a lot. You do need to remember a lot. But you're not doing complicated physics equations or mathematical equations such as in engineering. So you need people who've got intelligence, but they also need people skills, and it is useful if they've had some broader experience of the real world and are able to interact with people. Keeping in mind that you're selecting people at 18 and they're not going to come out the other side for at least 7, and then after they've worked in the hospital and get into their chosen field of medicine, maybe another 10 or 12 years, at which point you could be a completely different person. So then they decided, all right, well, that's not good. We're getting these real bright sparks, but they're not necessarily going to be that adept at dealing with with people, especially people who are not like themselves. Again, not saying that's across the board. We need a different system. We need an interview system. We need some other measures. Interestingly, before I went through, there was an interview process, and the allegation was made that, if you knew somebody or you were somebody's son or daughter, you got in, and that wasn't fair. So this hybrid system is this what they call aptitude test, which is the GAMSAT, which they say you can't study for, but everybody does. There's an interview process, so it's an amalgam. And also, a lot now have post-grad entry, which means that you've done some other course, probably in life sciences of some description, and maybe you're a little bit older, so you've got a little bit of world experience. So the aim is to bring in people who are necessarily intelligent, and that's we'll say that is important. And it's not to say that if people aren't academic that they don't have a valuable role. I mean, there's a lot of things that I could not possibly do that we need people to be able to do. So it's not one is better or worse than the other. But there are certain skill sets you need for certain professions. Like if you're good with your hands, that's good in some roles. If you're good at working out problems, that's good in other roles. It's never going to be perfect, but I suppose the system now is designed to look at what this person might be like as a doctor. Is it perfect? No. Does it work? Look, it does. Will they probably change it again at some stage? They probably will.
Now, Dr. J, if there was a student listening to this podcast today, what would be advice would you give them about the medical industry? Maybe something they will consider walking into this field. Just maybe one advice you will give somebody who's walking into this field of.
Yeah. Look, ultimately, if you want to make mega bucks, go into investment banking.
Okay.
Your stress levels will be up there, but you could well make mega bucks. There are no doctors out there who are either unemployed or starving, but there is also still this little bit of a view that if you become a doctor, you're going to be rolling in money. And I'm not saying that doctors are poor. Absolutely not saying that. But, there's a lot of occupation, a lot of roles where you can make far, far, far more money. So, look, you ultimately have to be interested in the human body and you have to be curious, and you need to come from a standpoint of I want to help people.
Beautiful.
And, equally, it's not like becoming a missionary. It's not. You need a degree of altruism, but also you need a degree of I'm doing a good job, and as a consequence of that, I'm entitled to earn an acceptable or reasonable amount of money for doing so, and B, you also have to remember that you need to look after yourself. There's a fair bit of burnout in medicine because people do get in and they are altruistic, and that's a good thing, but it can be taken too far, and then they're looking after the health of all these other people and sometimes neglecting their own health, and that's a problem. So you do need to make sure that you're also never forgetting to look after yourself.
That's maybe why I see you a lot of times. You love taking care of yourself. Now, Dr. J, I just want to shift a bit of gear in this sense, and one of the things I want to talk to you about, it's about your philosophy. Your philosophy is about empowering people to be able to get better, their wellness and all that. But you're working in a system that encourages, actually maybe rewards more illness than wellness. So how is this push and pull work for you, and how have you managed to be able either to influence or to change people's perspective? Because when you look at the system, it's more of rewarding illness. But you on the other side, you are more, hey, I'm going to reward wellness. How has that been for you?
Look, you're walking a line. Certainly we have not just in Australia, what is called a health system, but is actually a disease system. And it's interesting because the view is peddled, well, we're going to open more hospital beds, isn't the health system going well? A functional health system would actually regard needing less hospital beds as a marker of success, not opening more hospital beds as a marker of success. Again, not saying that as we sit here today, that may not be necessary. But ultimately, going back 50 plus years, most illness that was treated was acute illness. So you had an infection, some form of trauma, maybe your appendix, gallstones. So really more acute medicine. And it's interesting, Bobby Kennedy Jr. is now the Health and Human Services Secretary in the United States, observed, well, when he was a child, something like only 6% of the American population had a chronic disease. Now it's 60%. In Australia, that figure is not far behind. We have a large amount of chronic rather than acute disease. And 75 to 80% of that chronic illness is lifestyle related. So it's not that you've been run over by a truck. It's not that you've caught a bacteria. It's not that your appendix is about to burst. It is related to what you've been eating, how much or little weight you've got, whether you've smoked or not, how much you drink, whether you do exercise, are you getting enough sleep. And a lot of that is within the control of the individual. Not all, not 100%, but we have reached a stage, and this has evolved, again, probably over the last 40 to 50 years, that the idea is, well, do whatever you want, and if you do get sick, well, go to the doctor and they'll give you a pill. And we've got some great medications. We've got medications that can manage diabetes, we can help lower your blood pressure, we can lower your cholesterol, all these things are good. But we don't probably focus enough on, or maybe it didn't need to reach this point, and maybe there's things you can do to reverse it.
Knowing all that, how hard is it that we're spending so much money in a sense of the health system trying to do this? Like look at something like diabetic, sleeping apnea, or people being overweight. The government is spending so much money, but we have a system here that you've been standing and talking about it for so long that we want to be able to help our wellness. How is that so hard for maybe the medical industry or other doctors to be able? What is stopping us?
Look, there's a lot of issues in there, and look, we do see an increasing number of doctors wanting to get into well-being and what's sometimes called functional medicine, what's sometimes called wellness medicine. There's a lot of terms that are used, but essentially focusing more on probably holistic medicine is the other one that gets used. So, well, why don't we look more at the whole person rather than, as mentioned before, the specific disease, the specific organ or disease, and the two are not mutually exclusive. The system does tend to push people down certain paths. So, the medical education system does come from a very, what we call allopathic Western style. It says, really, you got high blood pressure, we're just going to treat you with tablets. You got high cholesterol, we're just going to treat you with tablets. You got diabetes, we're going to treat you with medication. There's a bit of lip service given to lifestyle measures, but not that much. Obviously, there's a lot of money for the pharmaceutical industry in selling medications. And look, it's an industry-wide issue. If you have a chronic medical condition, then you are potentially a client of the pharmaceutical industry for years and years, but you're also going to be going more to the doctor, to the chemist, to the pathology lab, for all the right reasons. There's not a criticism. But there are a lot of inbuilt, I suppose, benefits to everybody. And this is not a criticism of anybody. It's not that people aren't doing it for the money, but the system is configured that way. And also people have been a little bit conditioned to think, well, a pill is the answer. And there is a role for medications, obviously. Whereas the other way is also more putting it to the person. And the biggest problem, in my opinion, is these views that are peddled by, and this is my favourite hobby horse, big public health, that somehow society is to blame. So you hear these professors talk about an obesogenic environment. What a load of crap. What an absolute load of crap. There are foods that you can buy that if you eat too much of them, you'll put on weight. Absolutely. We see that in society. But I don't see any fast food outlet with some sort of crane at the top of it that picks your car up off the street, puts you through the drive-through, puts the food into you and forces it into your mouth. It is personal choice and personal responsibility. And the view that has been promulgated in health departments through big public health is that it's never your fault. And it's not about fault. It doesn't make you a bad person, but it is your responsibility. The idea that it is not your responsibility then feeds, well, it's not my responsibility. I should go and get a pill. And by the way, the government should pay for it because they did it to me rather than actually I'm responsible for what I do. So that's the biggest problem we face. And we saw this in the recent election where both sides of politics are bleating about free healthcare. It's not free. It's paid for by the taxpayer.
There's nothing free.
Yeah, there's only two options. Either you pay for a service, and this doesn't matter whether it's going to the doctor or getting a cab or buying your food. Either you pay for it or somebody else pays for it unless the provider is giving it to you for nothing. So if you go to see a doctor and the doctor says, I'm not going to charge you, I'm just happy to donate my time for nothing, that's free. Yeah. It's paid by the taxpayer, then it's paid by somebody, it's not free. And it's somebody else paying for your service. And look, we have a system, and it's fine that there is some government subsidy, that we do have, same with education and other areas, there's a role for government involvement. But the idea that it's free is completely wrong, and the idea that anybody is owed a living, like the world doesn't owe you a living.
Now, Dr. Josso, to sum that up on that point, is the system working for us or against us?
I think it's getting towards a tipping point where it has worked. I think the system we've got, like the Medicare system in Australia, was celebrated its 40th anniversary in 2024. And there's a fair view that it's been a very good system for Australia, but it hasn't evolved or changed with the times.
Yep.
And as we touched on before, disease patterns in the 1980s, very, very different to what we see today. So has the system worked quite well? Yeah, I think it has.
Okay.
Is it going to still, if we don't do anything about it, is it still going to work well in another decade? I don't think so. And in America, they're facing the idea that their Medicare system, which is different to ours, covers people over 65, and Medicaid, we bankrupt in the early 2030s. And if you look at Australia, between the Medicare system and its associates in health and the NDIS, we're also in a position where it could all bankrupt the country, which again, people need services, but the idea that it can all just be provided by a diminishing number of taxpayers is not going to end well. So what we've done is good. If we keep doing the same without recognition that the world, and when I say the world, that includes populations and patterns of illness and diseases changing, then it won't do so well in the future.
I want to hear this. I'm changing again, going to something else. We just talked about the system and all that. I want to hear this from you, particularly somebody who stands for wellness, not just about illness. Ozempic and those types of medication that have come in, and people are using them for weight loss and all that. Is there something that you will talk about? Are you somebody who's saying, yes, this is something that we should go to, which people will lose weight, their health will become better? Are you for or are you against? And what are the implications or maybe side effect of people using these things? Because so many people, I get these questions every day. And I'm not going to tell you my opinion on it, but I would like to hear that opinion from you.
It has a role. If you say, am I for or against it, I think it has a role to help people lose weight at the start, to get them kick-started, especially if there's a significant amount of weight to lose. Should people become fully reliant on it for the rest of their days, then the answer to that one is no. There's a real issue with losing body muscle instead of fat, and if you don't change your eating patterns, then as soon as you do come off it, then you're going to find the weight comes back on. And this surprised me when I saw this number, something like 30 to 35% of people stop within the first 3 to 6 months because of side effects. And look, cost is also an issue. Again, if people can afford it, that's fine. But it also fosters this idea that something needs to do it for me. So it's not up to me to change my eating patterns. I can use this medication and I can just sit back and the weight will come off. And for some people it does. And I really want to emphasise that it's not good or bad or right or wrong. It has a role, and that role is to help people, I think, where they've got major weight problems, I think what you might call morbidly obese, and really they just need something to give them a little bit of motivation, because if they lose the first, say, 5 or 10 kilos, and use that time to change eating patterns, then that might really give them incentive to continue. The people who want to lose 3 kilos and just can't be bothered making the effort, no, I don't think that's a good idea.
If I came to you as a doctor, can you give me maybe 1 or 2 things you would like you would like for me to tick before you could say, hey, I'm going to recommend you for this? Are there two things, or maybe one or two things you could say, okay, he's this, he's that, he's this, I could be able to recommend him to have Ozempic or that kind of medication?
Look, in simplest terms, probably the more overweight you are, the more of a role there will be for it.
Yeah.
But the way it tends to pan out in society is that it's almost the exact opposite, and that's partly a socioeconomic status and cost issue. No, I don't think there's set criteria per se. My suggestion to people would be this is an aid to, not the solution to, weight. So you do need to look at what you're eating. And people often say, look, I'm eating healthy. Yeah, that's good. Healthy food also has calories.
Yeah.
And then the other really big issue, and we could do a whole separate podcast on this topic, is the low-fat dietary guidelines. Now, if you look at pictures of people from before the early 1980s, you look at beach scenes in Australia, in fact, you look anywhere, not many people were overweight or obese. The introduction of the low-fat dietary guidelines has been the worst move ever in human health. There was never, and the staggering thing is there was never any evidence for it. There was never any data on it. It was just introduced. And you get all these foods that got a lot of sugar and they get 4.5 elephant stamps from the government, and people work on the basis that it's healthy for them. And it's not. And so I've eaten all this healthy food. They told me to have toast and breakfast cereal for breakfast, and I'm not losing any weight because you've had all these carbs. The carbohydrates, the sugars go into your bloodstream, and even if they're not sweet, that's the other trap for people. Goes into your bloodstream, causes the body to release insulin. Insulin is the body's fat storage hormone. Fine, that's what it does. You can go to the gym and you're in fat storage mode. You're not going to burn up a lot of fat.
I know this. I know, exactly.
So it is about changing eating patterns and breaking free of this mindset that if the government tells you it's healthy, that it is. It's almost the exact opposite.
Dr. I just want you to go back there to where the government or the medical, they stamp and say this is good for you. And somebody like you, or maybe a panel of people like you sitting there, they know this is not good. What can you or medical industry to do that? Because this is blowing the health population, and it puts more pressure on the taxpayers. And so is there no regulation that when a food like cereal say they're good for your breakfast, or it's not good for your breakfast?
Look, if you look at the ties of some of these panels that make these recommendations, and you look at the ties of some of these people to different industry bodies, and that variably can include agriculture, food, and pharmaceutical, that's a problem. And look, all of these industries have a legitimate profit motive. They want to make some money. That's how they do it. But they don't have a legitimate role in setting policies. Now, what I think is interesting too is that most of the world follows America. We all say we don't, but ultimately most trends come from America, and America led the way into the low-fat dietary guidelines. It came from there, and the rest of the world. Not all. Japan didn't adopt it, and Japan's got about a 3 or 4% overweight rate compared to 30 to 50 to 60% in Australia, UK, and other parts of the world. France also didn't go down this path so much. But America will also lead us out, and the changes that RFK Jr. is wanting to make in looking at how chronic disease is related to our lifestyles and the food chain in particular. And look, it's staggering that they're now banning additives and colorings in America that have not been allowed in other countries. Like there's some red dye that's been banned in Europe for years, and only now are they banning it in America. I find that staggering. So looking at the connections between what they call big ag, big food, and big pharma, everybody's clicking the ticket and you're getting unhealthy, and changing what we understand to be healthy eating, which is ultimately going back to the future, going back to what people ate probably until the late 70s, early 80s, which was your dinner was your meat, fish, chicken, and 3 veg. People might have had bacon and eggs for breakfast, maybe with some veg. Just getting back to those very basics and reducing the processed and packaged food, particularly processed and packaged foods with lots of sugars and lots of additives. Now, one other really important point. People say, these additives and preservatives, they're all safe. Yeah, they're safe. They're not killing you. That is absolutely the case. But it's the wrong question. Don't ask, is it safe? Ask, does it provide any nutritional value to the body and do I need it? And the answer to those ones is no.
Oh, this is something, if you ask me this, I think there is a misconnection between maybe somewhere there that something is being lost, and that's why we end up maybe people being given the wrong advice in that sense. I just want to move forward in this sense. There's so many doctors here now. There's influencers, there's Dr. Google, and there's Dr. ChatGPT. How has this changed in a sense of your role? Because maybe when somebody comes to you, they've already known what's maybe their problem because they've gone to Dr. Google or they've listened to some influencer on Facebook, Instagram, or blah, blah. Has that actually changed?
Not as much as you might think.
Yeah.
Back in the day, I remember my late mother used to have this medical encyclopedia and people would chat over the back fence. Sure, it goes to a next level, as you mentioned, with influencers and Google. I always say to patients, not everything on Google is right, but not everything is wrong either.
Yeah.
So there's
but
a
how
lot
do you
of,
know what's right and what's wrong?
Look, part of that can be looking at the sources.
Yeah.
And if you go onto websites, particularly if it's a website that's selling a product, and again, that's a legitimate, it's legitimate for people who want to sell products. But if there's a questionnaire and somehow, no matter how you answer the questions, the answer is going to be what they're selling, then you've got to be a little bit suspicious.
Red flags.
Also, are there some, references to what's being claimed? And, at one level also, does it make sense? And there's a lot of, like, these influencers, I think influencers probably are quite entertaining. I don't think they necessarily need to be taken all that seriously.
You're looking at somebody who doesn't know much, okay? Like the reason why I'm talking about this because my family uses this a lot. When you're sitting there, you say, "Oh, I'm feeling this." The first thing they go to it, and it influences how they think and communicate or what they think they should do. So I find there's a bit of yes, Dr. Google. Then when I come to Dr. Joe, I'm trying to compare the two.
Yeah. Look, the genie's out of the bottle and it's never going back in. My experience, look, people may have different experiences, is that a lot of people, if they come to see me, will say, look, I saw this on Google, but I actually wanted to run it by you.
Good.
Now, some people will go off on their own tangent. And look, in fairness, most of what these influencers talk about generally, again, there are going to be exceptions, is generally going to be relatively harmless.
Okay.
So you may not do you much good, but if they say to you to drink 3.2 litres of water instead of 2.5 or something like that, or say to take these vitamins, for example, it's very unlikely, and there might be specific circumstances, it's pretty unlikely that anything they suggest that you can ordinarily access just over the counter or in your normal daily life, that's probably going to cause you much harm. There are exceptions. It might not necessarily do you much good. And then typically if you try something for a while and there've been these claims made and you do it and nothing happens, you're probably going to say, well, that didn't work so well, and next time maybe I'll be a bit more questioning. So for all of that, probably not a lot of people are going to suffer significant harms, other than maybe they've spent some money that was a bit of a waste of money, but hey, it's a learning experience. But no, if you've got some, I'm trying to think how to put this politely, particularly these influencers who you get the sneaking suspicion that their appearance may have more to do with that they may have had some work done, and it's not just that they've been in the gym or that they're eating that well. They might be doing that as well, but that their appearance is either A, photoshopped, very often, and or B, they've had a lot of cosmetic work done, which again is their business. That's entitled to do. So it is a little bit, one just has to be a little bit suspicious. Hear it out. Take it with the proverbial grain of salt.
That's good. So there's a lot we have to learn from there. Now, you've been in the game for a while, okay? And when I say that, it's like you understand the system very well. What's one thing that you've seen in the medical industry that has actually gone worse and one thing in the medical industry that you've looked at it and goes, oh, this has actually grown or has progressed in a very positive way?
Look, what has gotten worse absolutely is the interference of bureaucracy and guidelines going from being just that, which is here's some ideas, to the attempt to impose a one-size-fits-all on every person.
Give us an example.
Well, look, the low-fat dietary guideline is probably a good example. The idea that there is a diet that suits every single person on the planet, and by the way, there are 8 billion of us. Again, targets, for example, with for example, cholesterol targets, again, assumes that everybody is at equal risk. If your cholesterol is slightly over the cutoff and you've got high blood pressure and you smoke, then your situation is very different to somebody who doesn't smoke and doesn't have high blood pressure and has the same cholesterol. So this one-size-fits-all approach. So the loss of individualization, and the theory has been, again, this comes from academia and big public health and government, is that we can't let doctors make decisions in conjunction with their patients as to what is best for the individual circumstances of that person, because they might get it wrong, which is possible. That is the nature of life. So therefore, we will impose from above these rules. So where guidelines became rules, I think that's been a major problem. So and the increasing advent of bureaucracy and compliance, more of an issue in hospitals as well. People spend more time filling out forms than they do actually trying to care for patients, and that's especially for the nurses. Look, I think in terms of getting better, I think one of the big advances that we're sort of looking at is genetic testing, which will eventually, we're not there yet, eventually really do lead to personalised medicine.
Okay.
So, for example, we don't have a single blood pressure medication that's going to lower everybody's blood pressure and do so without side effects. We don't. We know that there's, the drugs get approved because they're shown to work in a statistically significant number of people. Great. Does that help you? Well, you can try it and find out. So the ability to personalise medicine is an advance which is in its early stages, and imaging has also improved enormously. Look, the X-ray was a big advance, but in my career, CT scanning has become much more widely used. Ultrasound scanning, now MRI scanning, magnetic resonance imaging. You get far clearer images. Nothing is infallible, but the ability to do imaging has also been a big advance. The ability with blood testing also to find out more about the human body has been an advance. All of these things are a little bit dual-edged because we can end up jumping at shadows too. We can do images and find little spots that are actually quite harmless. They're not a problem they never would have been, but can send you around a cascade. But look, certainly, and people are living longer. Certainly in Australia, life expectancy is continuing to improve, and that is, that's.
You're very good with your numbers, I know. And guys, everything that Dr. Joe is talking about, if he's talking about numbers, dates, and everything, I can guarantee you this, he actually knows. Sometimes he annoys me when I'm talking to him and I'll ask him something and he would just go bang, 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 bang. So numbers and everything, this guy is just phenomenal, second to none. There's somebody who says he's a bit of a, what did Anna say? A bit of a genius when it comes to numbers.
All right.
You take it, okay?
I'll take it.
When you get given,
Thank
you
you.
take it.
Yeah.
Now, Joe, there's something that is coming, and for me, even from where I am as a trainer and a mindset coach, I'm actually a bit of wary. I was talking about this with one of my clients this morning. There's something called artificial intelligence that is coming in. And you're looking at robots coming in and doing these things. I think in the next 6 to 7 months, there is actually robots being tested in America to be able to drive people around, like taxi. Is there a fear in the industry that in time to come, most doctors who are operating or even doctors, their job could actually be going that way? Because with this, what I'm understanding, they'll be very precise. They know exactly what to do. Even I have that feeling. What's your take on such a thing?
Yeah, in the next decade, AI is going to revolutionise how aspects of medicine are practiced. Now, for example, robotic surgery is already with us, and the ability of AI to improve the precision of, you have a joint replacement, the precision of where the screws are placed, where the plate is placed, is going to continue to increase. The ability to diagnose lesions or spots on the skin is going to increase, because the ability of AI to do a correlation of a image so that the doctor takes a photo of your spot on your skin, that's new, puts it into the AI system. The AI system can correlate that one with a whole lot of similar ones where the pathology result has come back. So as a doctor, you can look at it and think, look, it looks like A or B or C, and the more experienced you are, the more likely you are to be correct. It'll never be 100%, it can't be. But the ability for AI to use the knowledge of thousands of doctors coupled with actual pathology results will be enormous. X-rays, with radiologists looking at X-rays and again basing it on their experience, the ability of AI to enhance that is also going to be significant.
Where does that leave some kid out there who their dream has always been to be a doctor, to be a surgeon, or something like that?
I'm not sure that that human interaction is ever going to go away. Human beings, it's hardwired like interacting with other human beings. Some more so, some less so. Some are introverts, some are extroverts. So I don't think I don't think it'll ever replace the ability to sit down with a person and tell them how you're feeling and what your problems are. Maybe in some instances, yes, but largely no. So I think the fields in medicine where it's very person orientated, so I'm thinking about probably psychiatry, pediatrics, general practice, a lot of general physicians where they're spending a bit more of their time talking to people. I think AI will support that. Some of the roles where maybe it is more, if in inverted commas, mechanical, that role will change. It will be more an oversight role, because ultimately I don't see the final decision being passed across to AI at any time in the foreseeable future. So I think, even as mentioned before, with looking at the lesions on the skin or looking at images for a radiologist, a person will still need to make the final call. But might it be that we need less of those people? Now, might that feed into loosening up or freeing up people's time, therefore making access to doctors better? I mean, that'll be interesting to see, and that's a possibility. And can the time of doctors then be freed up to spend more time, actually with the individual patient? That's also could potentially a big plus. But at the start, it's probably going to be messy.
Sometimes the next thing I want to talk about, it's as good as artificial intelligence is, you're not going to get to where I'm going to go with this next question. You've been an advocate for cannabis. Some people out there have spoken about it, saying it's hyped up, it doesn't actually meet what it's supposed to do. What is your take? I would like to understand what is the pro, what are the cons, and where you stand with that.
Medicinal cannabis, and I've got to point out that I'm medical advisor to Little Green Pharma, which is a medicinal cannabis company. It's like any other medication, has a role for certain people in certain circumstances. It's not a cure-all. People will say, it's a cure for cancer, it's a cure for everything. No, it isn't. At the other end of the spectrum, you've got people, it doesn't work, there's no evidence. Yeah, it does, and there is. So for people with chronic pain, with anxiety, with PTSD, with insomnia, there are a number of conditions where medicinal cannabis can be helpful. Now, does everybody who takes it get a benefit? No. As I said before, not everybody who takes a blood pressure medication that's been listed gets lower blood pressure. Not everybody who takes paracetamol finds their headache gets better. So nothing works for everybody in all circumstances. But probably 3/4 of people who use medicinal cannabis will find some improvement in their symptoms. It's not curing the underlying problem. Again, very important take. And in Australia, it is a requirement that people have tried other treatments first. So it cannot be the first line or the first go-to. So I think we are now probably nearly 8 years down the track. We are now in a situation where it is becoming part of the landscape. It is a treatment option. It's not suitable for everybody, but it can help. It can help a reasonable number of people, and certainly can be considered if the symptoms warrant it, and there's no particular reason. There may be particular reasons why people can't take it.
On a personal, maybe on a personal level, what made you feel like that was a role? Somebody who's very high in the society, in the community. Yeah, you take it, Dr. Joe. What made you feel like that was an alternative? Because I think most people, most doctors will shy away from it. What kind of things did you see, or maybe evidence that made you go, okay, this is something I do believe in, and I would like to put my hand up? I know you like going where most people don't like going, wellness, exercise. So
Look,
it's
I
in
think
your
you've answered.
DNA.
You just about answered your question there, Tom. Look, I was approached by the inaugural CEO of Little Green Farmer, Fleta Solomon, who I'd worked with her in another business in the 2000s, to look into it for her. She had been presented with an opportunity to run a startup company, which is what's now known as Little Green Farmer, and said, "Look, Joe, can you have a look at this from a medical hat? What do you think about it?" And I knew nothing about it at that stage. And if you'd have asked me a decade ago about cannabis, I'd have probably said the same as everybody else. Oh, it's this terrible, substance. But you start to look into it and actually get some data and facts and find out, number one, it was used medically until the 1930s in a large number of jurisdictions around the world for similar reasons to now. Two, you look at what's gone on in various states in the US, in Canada, in Israel since the 1990s and 2000s, that people have been using it medicinally, it's been manufactured, prescribed by doctors, and that there has been improvement in symptoms with people using medicinal cannabis. So you then say, oh, they never told me about that in medical school. I haven't read that on the front page of the medical journal. Okay, there is actually a role for this, and we know that because A, international jurisdictions have shown that, and B, look, we also know that there have been a lot of people who have been self-medicating, which obviously is not recommended and people should not be doing that, but it hasn't stopped them. And people will say, look, I tried all these other different medications, it didn't help my variably sleep, pain or anxiety, so I've sort of been doing this on the side. So that will be classed as anecdotal, but if you've got enough anecdotes and enough people doing it right around the world, and possibly and literally for thousands of years, you bundle all that together, and it says, yes, there is some value in this, and the main reason that we've not been using it does date back to the 1930s, which again is a whole other story with prohibition. And if we strip away the mythology, if we strip away the bias, and we look at it as a medication, then it can have a role. And interestingly also, it's not an anti-medication. We have a lot of anti-drugs. We have antihypertensives, antidepressants. They all have a role that's good. Cannabis works more in harmony with the human body, which has its own endocannabinoid system. And like any physiological system in the body, if that gets out of balance, it will manifest as some problems. And introducing exogenous cannabis, again, where it's suitable for that person, where the symptoms warrant it, and they've failed other treatments, then it can cause some rebalance. And some people will get dramatic improvement. Some people will say, look, I'm better on than off, and some people will say this has done nothing for me, as with all medications.
Are we misinformed?
Look, short answer to that question is yes. Again, if you go into the actual data and actual science as against what's promulgated by politicians and health departments, dare I say, it's not a dangerous substance. You cannot fatally overdose on cannabis alone. When you get celebrities who've overdosed, they've got a lot found in their system, and THC, which is one of the cannabinoids, is one of those, but that's not what's killed them. And weight for weight, compared to a lot of other substances, including tobacco, alcohol, and caffeine, weight for weight, it is not highly addictive. Again, if it's misused, too much, too often, too high a strength, you're going to get addicted. Yes. But weight for weight, not so much. There's a lot of mythology around cannabis, which dates back initially to the 1930s, and it's an interesting political story, and followed up in the 1960s when that political story was doubled down on. So there's a lot of bias, and that bias is based on mythology and, unfortunately, an unwillingness for people who, on the one hand, scream, we've got to have evidence, here it is, oh, I don't care.
It's not what I'm looking for.
Yeah, it's not what I wanted to see, so it doesn't count.
Yeah, now, Dr. J, I've got so many questions, but I'm going to end up with this question because I love listening about these things because most of the time we are so misinformed, and we make our own judgment on that sense. But I want to now shift to you. You've changed your role a little bit to be into the media, and you're a public figure. You're into media, which traditionally most doctors don't do that. What is some of the challenge you've been able to face, transitioning from being a doctor to being a public figure, speaker, and in that sense? What are the challenges?
Look, I suppose I've been in the media for the best part of 30 years, and that was originally as a spokesperson for the Australian Medical Association in the 90s. So that got me in, and then even when I finished up official roles, the phone kept ringing. Look, the challenge is you cannot solve anybody's problem in the media. So when asked to give comment, you cannot give advice to anybody. It's not possible. You can give some general information. There's a fine line to be walked between providing information for people to consider and sounding like you're telling people what to do. And that's a really, really important line to make sure that it's on the information side. To me, it's been useful for a number of reasons, including it keeps you across new developments. So I get a number of medical news letters that you can just scan across and think, oh, that's new, that's interesting, I haven't come across that. And particularly coming out of America, as I said before, because we typically follow them. And number two, and this got into the public speaking in the book, I can talk to people one at a time about weight, diet, exercise, sleep, relaxation, stress management, and, or I can do one to many. And a podcast or on the media or an article or a book is the one to many. And that's initially what got me to write the book, 15 years ago, was hopefully that this message, which is a message that nothing is 100% universal, nothing is, that this message is one that's going to benefit lots of people, and if it's in a book form or in some other more mass media form, it's not me having to do it one person at a time. It's the ability to get information out to the many.
Now, I want to wind up by asking you this question. What has been the most challenging thing in your role as a doctor? And what is one thing that you've been really happy with?
Look, I think when you can make an impact on people's lives, and sometimes people come back and they might have lost weight or they might have given up smoking. Oh, you said X or Y at some point in time. It might not even have been recently, and that you've been able to impact somebody's life. I think that is always the plus. Flipped on its head, look, I think there's always going to be times when it just didn't go as everybody had hoped. Not always because anybody's done anything wrong, but just it hasn't gone as hoped and planned, and the outcome is not a good one, and that's always and that's obviously always sad. But it also comes with the territory.
Dr. Joe, I just want to say thank you for sharing for answering some of those questions. And I will finish up by saying I'm really grateful to have this moment to get the inside and also just to get your knowledge about a few things. And thank you so much.
Tom, it's been a pleasure.
I appreciate you. Thank you.